Clinical application. This is where theory becomes practice. Every deviation you see must be related back to range of motion, strength, motor control, pain, balance, neurologic input. Gait analysis should guide exercise selection, orthotic use, gait retraining, and progression towards return to function. An example, a stroke patient with drop foot is not just weak. They need an AFO for safety, NMES for timing, active dorsiflexor retraining, and task-specific gait practice. Physical therapy assessment tools. Gait analysis does not exist in isolation. We use objective tools to support what we observe. Walking speed and endurance tests such as the 10-meter walk test, timed up and go, a 6-minute walk test. These tell us about functional capacity. Observational gait analysis allows us to identify deviations. Standardized assessments like the Tonetti and the Dynamic Gait Index add reliability and validity. Lab-based gait analysis provides detailed data but is not always clinically accessible. Systematic gait analysis framework. This framework should guide every gait evaluation you perform. You want to observe first. Observe in the sagittal plane, then the frontal plane, and then the transverse plane. Then divide gait into phases. Ask, what is abnormal? Why is it happening? And what impairment could cause this? Then confirm with objective testing. Never test blindly. Okay, now focusing in more specifically for each joint. For hip-related gait deviations, assess strength of the gluteus medius, gluteus maximus, and the hip flexors. Test the range of motion for hip extension, which is critical for terminal stance, internal and external rotation, which affect transverse plane control. Special tests, testing Thomas, Faber, Faydier, and Scour. Some functional tests, single leg stance for balance, and a step down test. These tests confirm what Gait already showed you. Now for the knee. Knee deviations require assessment of strength of the quadriceps and hamstrings, testing range of motion. Full extension is essential for efficient stance. Special tests such as Lachman, anterior drawer, varus/valgus stress, McMurray, and Thessaly. Functional tests of doing sit to stand, step down, and squat mechanics. For ankle and foot deviations, assess strength of tibialis anterior and gastroc and soleus. Testing range of motion. You want to test both ankle dorsiflexion and plantar flexion while non-weight bearing, and also test dorsiflexion in weight bearing. Special tests such as the anterior drawer, assessing if there's talar tilt, or windlass for plantar fasciitis. Functional tests such as the foot posture index, or seeing if there's a navicular drop. Again, remember, foot mechanics influence the entire chain. Now putting it all together. This is where clinical expertise lives. You must determine primary versus secondary deviations, impairment versus compensation, and which impairments limit function most. Again, thinking about treating the root cause, not the adaptation.